Thank you for joining us for today's webinar, Stress Relationships and Substance Use Disorders, an Introduction to Neuroscience-Informed Counseling. My name is Marla Kaufman, and I'm the Communication and Health Promotion Coordinator at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar via two methods. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Dr. Chad Luke, will leave time at the end of the presentation to answer questions. Feel free to submit your questions via the chat or the Q&A box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. You can also request a general certificate of attendance at no charge. Please note that it will take up to 48 hours for your CEUs to be available in your My IRETA profile because we have to cross-check your attendance on the webinar with the WebEx system. After the webinar, you'll receive several follow-up emails. The first will be an email with a link to the evaluation. The second will have information on how to access your certificate of attendance and continuing education credits through your My IRETA account. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter, Dr. Chad Luke. Dr. Chad Luke is a counselor educator at Tennessee Tech University in Cookeville, Tennessee, a licensed professional counselor, and a clinical supervisor. He has clinical experience with addictions, children and adolescents, unhoused adults, college students, and other adults. He is the author of Neuroscience for Counselors and Therapists, Integrating the Sciences of Brain and Mind, 2nd edition, published by Cognella. Okay, Dr. Luke, if you're ready, I will hand things over to you.
Sounds good, Marla. Thank you. Can you hear me okay?
Yep, loud and clear.
Good. I never know. Well, hi, everyone. Thanks for being here. Thanks for spending your lunchtime or breakfast or dinner, depending on what shift you're working and where you are in your life at the time that you view this. I'm pretty excited to be here. I have some notes on another screen to try to keep me on track because I get really excited about this topic and veer off kind of quickly. So I will try to pull myself back, and I welcome your comments in the chat. I think the team will be monitoring those, and so if there's some questions that come up, I'm happy to address those as we go through. So, okay, let's talk about a little first, just the goals for today, and these are the goals that you kind of signed up for. So we want to discuss the foundations of what it means to incorporate neuroscience into practice. I want to describe a type of neuroscience-informed model and where that exists along the continuum of models for substance use treatment. And then look at the relationship between stress relationships and substance use disorders, and especially tied together through neuroscience. Along the way, you will hear me use interchangeably addiction and substance use disorder. Addiction is a tricky term, but it's a term that can be fairly all-encompassing. So I use it as sort of a shortcut because a lot of the work that we're talking about here, the research applies to both process addictions and substance use disorders, chemical addictions at the neurobiological level. And so I use addiction more colloquially than specifically. So I don't want to offend anyone by using that term. I think it's a term that we're used to using, even though it's not particularly well defined in the neuroscience of addiction literature. Okay, so that's what I've said the goals could be for today. But what I'm really interested in is what you want from today. So, and I start sessions, whether it's supervision or counseling sessions or training sessions or classes that I teach, with a similar kind of prompt. There's a tapping sound. Okay, I'll try to stop tapping, or whatever that is. So let me know if it doesn't get better, okay? So the main thing I want to know, you don't have to tell me in the chat necessarily, but you can, is what do you want from today? What did you sign up for? Some of us will need continuing ed credits for our license certifications and work lives. Some will want some tips for how to enhance their practice. Others have other reasons. But it's most important that you know what you want from today. And because that's the only way we can measure if I've done what I set out to do, is if you know what you want, and at the end you're able to see if we met what you want. So you know kind of where I'm coming from, and then you know where you're coming from. Okay, so what I'd like to do now is, and this is part of my self-regulation as I get so excited about this material, is I'd like for you to think about two things. The first is I would like for us to take a moment and just feel the awareness of the grief that we have all experienced and may experience due to the tremendous losses that have occurred due to addiction. The implosion of families, the self-destruction of individuals, the breaking of relationships. I think that is, if you'll pardon the term, a sobering way to begin, because we confront grief all the time, every day in this work. And I think we have to be on good terms with our grief so that we can think clearly, behave genuinely, and really connect with the person that we're working with. I'll give you a moment to think about the grief that you bring with you today over the losses that we've seen, shared, witnessed, directly experienced. The second thing I'd like for us to take a moment to do is to reflect on the gratitude that we can experience for having the privilege of learning about the human experience through addiction. I didn't know what the human experience was and what it was like to live as a human until I worked in addictions. And it gave me a framework for understanding the earlier life experiences that I had around destructive behaviors. And so the privilege of working with clients who struggle with substance use disorder, or substance misuse, or addiction, whatever term we use, is an opportunity for us to know ourselves better. And that's why I'm forever grateful to all my clients, those who scared me, those who inspired me. They all inspired me. But the whole continuum of our work with them. And so I feel like grief and gratitude have equal parts in our space today. And I just want to honor that as we get started. And I will say that I do see chat bars pop up, but I have very much a squirrel brain. So I see them, I'm distracted, and then I can't read them and think at the same time. So I just want to recognize that I appreciate your feedback that you're giving and the interaction that we're having today already. That means a lot. I apologize in advance if I'm not able to respond in a way that I would like to, based on my, squirrel brain. Okay, so let's start. We'll just take our next step with a couple of poll questions. And I think, Marla, you are in charge of that. Oh, here we go. So if you take a minute, the degree is really yes or no. I am familiar with neuroscience-informed counseling or practice, sometimes called neurocounseling, because it's the first prompt. The second is I feel confident in my ability to integrate neuroscience and neuroscience-informed counseling or practice into my work with individuals with addiction. And that asterisk is with addiction, with substance misuse, substance use disorders. So I'll give you a moment to do that.
All right, I'm going to close the poll in about 30 seconds. So if you haven't done it yet, please do that now.
Okay. Thank you, Marla, for doing that. Is everyone able to see the results, or do I need to read them off?
Everyone should be able to see them.
Okay. So about 70% are familiar with this. And so that might help me understand part of what your expectations are for today to increase your familiarity with this. 50% no, and then feel confident. 6% feel confident, 25% not confident, and 34% unsure. Yeah, so thank you for running that, Marla. I appreciate it a lot. And thank you for responding. I just want to draw attention to that 34% in second question of unsure. I'm encouraged by that number. A third of us are not sure if we're confident or not. And that's where we want the field to, I want the field to be, is a place of humility to say, I'm not sure I even know what we're talking about. And if I don't know what we're talking about, how can I be confident in how to integrate it? And so I'm hoping today to be able to walk you through some ways to familiarize yourself with the work, the body of literature that exists in this area, and also increase some of your confidence in how to apply this ethically and effectively. And that's been the bulk of my writing about neuroscience over the last number of years, 6 or 8 years, maybe 6 or 7, anyway, is how to do this ethically and effectively. So thanks again for participating in that. So, okay, I have about 8 hours worth of material that I want to share with you today. And I know we only have 90 minutes, 76 minutes now. So in order to do some of this, I want to frame today's work. So I wrote this for just sort of map this out for the latest book, the 2020 Neuroscience for Counselors and Therapists book, to give us an idea of the scope of the work. And so today we're really going to look at some basics about the foundations and some basics in terms of preliminary considerations. So if you're looking at the pie chart, about 11 o'clock is the preliminary considerations. At 9 o'clock, we're looking at substance use disorders specifically. That's sort of confusing using the clock because different time zone. Okay, and then also we're going to look at a little bit of the foundations of application. But as I was saying to someone earlier, I have slides in here just by themselves could be a whole presentation. Well, in fact, I teach a course on neuroscience for counselors, and so it's 15 weeks, so 45 hours of content. So I'm trying to condense that just to get you a little bit excited about this topic and to inspire you to read more. Now, on the way to doing that, I'm going to do a couple things that are a little bit different for me and sometimes different from what people say they want in webinars. So one of the things that I've done is I have not included case material today. And I know we'd like to see cases displayed and talked through. Because so much of this is foundational, I feel like it has to be more information-based. And also, most of my experience with using cases in presentations is we can all think of exceptions to the application. And so it can be harder, it can be a distraction from us being able to get some of the basic principles. So Nothing I say today, well, few things I should say that I'll say today will be applicable to every person 100% of the time. The second thing I'm doing is a little bit different, is I've put a lot of content on the slides because one, I believe this is being recorded and you'll have access to it later. And so I don't want to have the skeletal outline of slides where if you're not at a place where you can take notes or don't want to take notes, then you won't be able to follow back through as afterward. And so I've tried to create a narrative of how this application works throughout the slides. So that's why they're a little bit more content heavy, and I'm violating some of the rules of PowerPoint or slide presentations. Okay, so it seems like I have a lot of preliminary things, but it's all preliminary in my mind. I want to give you 6 assumptions that I operate from in approaching this work. And they're sort of a distillation of 10 tips that I just created a workshop on for Mental Health Academy. So it's really reduced down. But I want to just walk through a little bit. Is that my assumption is that we approach new neuroscience findings with caution, even some skepticism, because this knowledge emerges quickly. And so it's important for us to maintain tried and true methods of building relationships and using interventions. So regardless of what you read in neuroscience, popular neuroscience, anything that violates the power of the relationship in working with individuals with addiction or substance use disorders or substance misuse is not something you want to just be very careful with that kind of information. It shouldn't conflict, but if it does, we come back to sort of the foundation of who we are as helpers, building relationships with folks. Okay. So assumption 2 is that neuroscience views the mind as mere biological processes. In practice, however, it may still be useful to describe the mind's influence on the brain and vice versa. So neuroscience, 98% of neuroscientists believe that the material world is all there is, and that all that is in human experience is neurobiologically based. But I think folks who work in addictions treatment know that there is value in leaving room for the unexplainable, the inscrutable, the transcendent. Even if you're not in a spiritual-based program, there's a lot we don't know about what happens. And so even as we understand more about physiological processes, there's still room. For example, my daughter was talking about her anxiety in the evening. She's almost 12. And she says, well, I have to do these things to trick my brain so that I feel calm. I'm like, well, that sounds really practical. I wonder if I could learn that myself from her, because that seems like something I could use. But when she says, I have to trick my brain, who is the I in that? Is the I just the brain tricking the brain, or is there a mentalizing process, a transcendent process that makes sense for us to think about how we influence the mind? What is the we that's doing the influencing? Neuroscience just reduces it all down to material processes. I think there's something else there. I'm not trying to step on anyone's beliefs, but I think it's a good thing for us to challenge is the material world all that is there, especially when it comes to spontaneous remission from addiction or entrenchment in addiction despite multiple interventions and treatment protocols. So more room for humility there, I think. Assumption 3 is that a wellness orientation is the bedrock of counseling. The problem is that well people don't tend to seek treatment. So one of the most frustrating things about our work in addictions, I think, and you can tell me if you disagree with this or if you agree, is that we get people late in the process. We don't get to be as developmental as we'd like. Let's look for warning signs. Let's look for signs that this person may be putting themselves at risk for a substance use disorder. We get them after they've met the criteria. In a lot of cases, there are some programs that are exceptional, and that's really wonderful. So the question then from a neuroscience perspective, and based on some principles that we'll see, is how can we meet people experiencing pathology, and still maintain a wellness orientation? And so this is something that's really valuable for me, is that, and this is common in addiction practice, I think, if it's not, I think it should be more broadly applied, is there is the dual element of letting go of destructive behavior while also filling one's life with values-based behaviors. So in what ways can we fill your life with things that are aligned with your values? And it can be relationships, it can be art, it can be music, it can be work, whatever, such that you start to crowd out the room that the substance use disorder takes up. A lot of times it's presented as, well, let's get you clean and then let's get you doing something productive. And I wonder if there's a way that we could do both simultaneously. Just a question for thinking later. Okay, number 4, I've got to keep moving. Neuroscience is inspiring, but it cannot suddenly provide the answer for all our clients' suffering. More information about the brain is not the same as more knowledge or the wisdom in how to use it. And I think this is the seduction scene that is neuroscience, is counselors, helpers, whether you're at LADAC or nursing or whatever your role is in working with addiction, is that we are bombarded with the difficulties of the people that we serve, the people that we walk alongside of, and just a lot of exposure to pain and damage. And we would love to have an infusion of hope that we haven't experienced before. We like the idea of there being something unknown to us before that now is going to come in and kind of be the silver bullet or the missing treatment link that we've been waiting for. And I think as long as we can keep our expectations modest, knowing that we have experienced a lot of grief and gratitude in this work, will not be taken in by superficial applications of neuroscience that's not fully founded on real research. Okay, number 5. Like many contemporary psychodynamically oriented counselors have begun to conclude, is that insight can be necessary, but it's not sufficient for change. So even though neuroscience can help us understand and gain some insights into how addiction works, it's no substitute for how we support clients in helping them experience and experiment with different behaviors. And I think this is a crucial piece of this work, is neuroscience provides some whys, but really we want to focus away from why into what and how. So what are the mechanisms of addiction, and how can we use that knowledge to expand the behavioral options of the people that we serve? Okay, number 6. Integrating neuroscience with counseling, it doesn't require us to become neuroscientists. It doesn't require us to be experts in there. I'm certainly no expert. Every day I read something that helps me realize I don't know as much as I might have thought I did. So one of the most important pieces of this in my way of thinking is understanding the sources of our neuroscience information. So I want to give you a slide and just give you an idea of what I'm talking about here. So I've ordered them reverse order from, like, you might call it depth, but more lab-based up to number 1 is more techniques-based. So you may have heard of the principle of neurons that fire together wire together, and that's part of neuroplasticity. And this is Donald Hebb's work studied in the lab using animal models. And then the next level is Sweat and colleagues took some of this research into translational science, which is how do we understand human behavior, the underlying mechanisms of human behavior, to then theory-based applications. You may have read Dan Siegel's work or Lou Cozzolino's work on trying to make sense of all this neuroscience literature and also human functioning, thinking, feeling, behaving, and relating. And then that comes down to, and these are sort of artificial. I'm trying to give you just a continuum to help frame the discussion still, is applied stuff. So Bickle and colleagues, and I also have another slide about this, showed that memory training actually helps substance abusers or misusers in their experience of what's called delay discounting. I'll talk about that a little more. But the idea here is that the further we get away from the bench science, as it's called, like a lab bench, the more interpretation is involved in how we understand that. And so we just want to be mindful of what we're reading, that like a game of telephone, the further we get away from the source, the more accessible it might become, but maybe it loses some accuracy. And that's not an inherent problem if we're aware of that. All right, let's see what's next. I'm always interested. Okay, so what is neuroscience informed practice or counseling? I don't know, but I'll tell you what I think. So counseling practice that uses the findings of neurobiology, and that's neuroanatomy and neurophysiology. That includes the study of the brain and the central nervous system, the peripheral nervous system, and the enteric nervous system, to better understand and improve human experience. So it's always about helping people live more well and less ill. Its application for helpers is most appropriately implemented through linguistic devices like metaphor, similes, analogies. That's my own work, to understand human functioning throughout the brain. And I'm going to give you a number of those as we move through this, if I can speed it up, to give you an idea of what I'm talking about. So that's sort of a working definition. It may change by the end of this presentation. That's a part of the challenge that my colleagues and I write about, is that we don't have an agreed upon definition. And so clinicians, practitioners are left to kind of try to make sense of it on their own. But we're getting close. So we should see a couple of publications in the next several months that help inform that. Okay. Just looking at my notes to make sure. So for me, understanding the brain, used to be mostly excited about neurons and, their axons in the body of the cell and the dendrites. In my writings, I use this 5-4-3-2-1 heuristic. It's really 1-2-5. One brain, two hemispheres, three functional levels, 4 lobes and 5 systems. These are just the ones that I focus on and the way it makes sense in my brain. So one brain emphasizes holism, the whole person. We can't separate parts off, as the Gestalt therapist would say. 2 hemispheres that I'll talk about in a little bit. One really focused on literal interpretations of facts, and one on creativity and holistic pictures, connected by the corpus callosum, the bundle of nerves that helps them communicate together, because we need both. I'll say more about that in a little bit. The 3 levels of functioning is something else that we'll come back to, but really like the, I guess you'd say the lizard brain, which is like base functioning, if you've ever seen a lizard behave, and then the rat brain, and then monkey brain or human brain. And it's a model that's grown a little out of fashion, but I think for us understanding, it's useful. So we take a version of this in a book that is coming out soon, which I'm so excited about. I'm not here to hawk books, but it's neuroscience for child and adolescent counselors working, and I have a chapter on there on addiction. But my colleague writes about lizard versus wizard brain. So the lizard brain is the reactive, reflexive, always startled, and the wizard brain is the wise brain. And so it can be a shortcut in treatment for, are you operating right now from the lizard brain or from the wizard brain? And how can we make that adjustment? And then the 5 systems, we won't have time to go into those today, but they all serve a function. They're all part of this whole. All right. I don't know if there are any burning questions. I might check in with Marla and just see before we jump to the next part if there are questions that maybe I could attend to or comments.
Yeah, just a few comments so far. lots of positive folks saying how intriguing this all is. And one person said, whenever you were speaking about your daughter and talking about her anxiety, it's somebody said IFS would view this as the genuine self.
Yeah. Great.
But that's everything so far.
Okay. Yeah, thanks. Keep it coming in. Because the more questions you ask or comments you make, the less I just sort of blah, blah, blah at you. Okay, so let's move into this a little bit more. First with a poll question. So what is your primary model of addiction? Again, with that asterisk. I think Marla will help us there again with a poll question. Marla, could we give maybe a total of 30 seconds on that one? If not, it's fine.
Sure.
Thanks. Wait to see what you all say. Okay, great. Thank you. Let's see. Other. Okay, so we have 100. Is that 100 responses out of 195? Okay. The largest portion is the medical model, brain disease. Oh, I'd really love to hear what that means to you. Let's talk afterward. Oh, wait, we're not. Okay. Look at the distribution here, if you would. Moral model, self-medication model, AA, and I recognize that there's some overlap here, and then other. Could you just throw a comment in the chat if you have another model that you practice from that you want to share? Can do that throughout.
Someone mentioned the biopsychosocial model, but they messaged it right to me.
Okay. Yeah, love that model. That's great.
Harm
Biology of
reduction.
desire.
Someone just said harm reduction.
Harm reduction. Yeah. Oh boy, that's a minefield, isn't it? Thank you for bringing that up. Yeah, I see someone said they just couldn't pick one. Well, I want to say a little more about why that's so hard. Patient-centered. Wouldn't that be amazing? I have to tell you this. I have this article on teaching counseling theory, and my point in writing the article was that if we know our theories well enough, we can work with clients in a way that they get to choose their own explanation for their symptoms rather than us imposing our worldview on them. Wouldn't that be amazing? I don't know. I'll show you why I think that's true and how I understand that in a little bit. Okay, but I have to be focused. So Margaret Fetting describes 10 different models of addiction. And this is really a challenge for us as a field is, what is addiction? Is it okay to call it addiction? Is it substance use disorder? Does it become addiction? And a lot of the neuroscience literature says it becomes addiction when it's a substance use disorder that's moved from moderate to severe. I haven't seen that in the DSM, but it's just kind of fascinating how we start to conceptualize this. So again, I'm not going to go over all of these, but I want you to just see the complication that we experience with all these different definitions. And then I want to just highlight a couple of additional ones that make it even more complex. Here's the biopsychosocial model that someone, dual diagnosis or co-occurring, harm reduction model, sorry, can't control my mouse. And then, so here's a few more that from like the neuroscience world. Well, the DSM says it's a pattern of substance misuse, and you have to check these boxes. We also know from our work that people can be completely self-destructive and maybe not meet those criteria, which is a limit to how much treatment they get. Koob talks about this. I have another slide on this, that it is a reward deficit and stress surfeit disorder, which, you know, I don't understand why I can't say a stress surplus, but I'm not a neuroscience scientist. But the idea that we in our addiction don't experience rewards that in ways that other people do, and we don't experience stress in the same ways that others do. And I saw a question pop up, but we'll maybe catch that in a little bit if that's okay. Some have written it as an attachment disorder, and I think there's some really interesting work around there. I call it a relational disorder just because I wrote a book and I wanted to, no, I'm just kidding. It feels truest to me, and that's reductive because there's a lot of other things going on. But then something that, again, we won't have time to cover this, and I put the slides in and I took them out and back and forth on the research domain criteria, which is an initiative by the National Institute of Health and the National Institute of Mental Health to develop a taxonomy and an understanding of the neurobiological mechanisms underlying a host of psychological disorders. And so they have a number of systems. They have the negative valence system and the positive valence system. So for example, the negative valence system is acute threat or fear, potential threat, anxiety, sustained threat or loss, or frustrated non-reward. So this is sort of the negative. Positive, like reward responsiveness, reward learning, and reward valuation. So how do we experience something as rewarding or not rewarding? And I think that's a really helpful way to understand addiction, because what it does is it looks beyond symptoms and into underlying neurobiological mechanisms that underlie a variety of things. So, for example, why does anxiety look a lot like ADHD and look a lot like depression, depending on the person that you're working with? What are the overlaps between alcohol use disorder or opioid use disorder? Why are alcohol use disorders and opioid use disorders both responsive to Vivitrol? Like they're completely different substances, different psychoactive properties, and yet so that's the kind of work that the research domain criteria is seeking to illuminate. And it's really deep and detailed. And so that's that's another presentation. We have an article on this about whether it adds to or takes away from the field by using this explanation. So, all right. You may be familiar with this. I've seen it credited as a Chinese proverb, as a Arabic proverb. I don't know who gets credit for it, but you've probably seen it. The man takes a drink, the drink takes a drink, and the drink takes the man. This is a really apt description of addiction for people who experience addiction differently than people who are able to drink unproblematically, which is probably fewer than we recognize. So I saw that reference to endorphins. Yep, we'll come back around. Thank you. So we're going to come back to this as we get a little further into the mechanisms in the brain related to addiction. So let's get into this next piece. This is just another wheel. Apparently I like wheels, and it's my neuroscience perspective. So the first thing you'll notice is that maybe your favorite domain doesn't appear to be represented here, and that's fine. only had so many spokes to work with. I do think that the majority of domains that we're talking about with addiction and with the human experience can be subsumed under these. So if you ask, where is spirituality? And I situate that in the sociocultural milieu. You may have questions about other things. So what I want to try to do as briefly as possible is give you an overview of these 8 factors. They're not new. These are not mine. I didn't come up with the word thoughts or the concept of how important feelings are in treatment. But the way that they make sense in my mind is a little bit different than what I've seen in other publications. Also, what I'm going to show you over the next 8 slides is the neurobiological basis for each of these, and then a whole gestalt of this model applied to addiction. Like I said, I have a chapter on that. Again, if you want to know more about this, if you're interested, there are ways to access some of that information. And so, okay, it is my way of conceptualizing client concerns, especially for the students and the clinicians that I work with and supervise and consult with who have varying understandings of addiction. They approach substance use disorders from one of the 10 or 15 models that are out there. And this is sort of transcends that, because for every person that we work with, here's the way I explain it in another place, is the sociocultural milieu exists before we were born, right? So family that will ultimately be our family, whether we're born into our biological family and live there, or another family, adopted or surrogate family, the cultural beliefs, so race, ethnicity, gender, religion or spiritual views, all of those things pre-exist our being. So they're there first. And then next comes sort of the biology, the genetics that we're born with, but almost immediately that's taken over by the relationships in our lives. And so you have this progression, and I'll present these in the same order, that lead to the immediate environment that we're born into that later comes out as past and current environment, then experiences that we have within those contexts, and those experiences are understood within those layers of identity. And then those affect thinking, behavior, and then feelings. And you'll notice that's a little bit different than the cognitive triad. So I feel like I should pause, but I don't have time to pause. Okay, just send your messages or your questions, and we'll get a break after these and see where we go. Again, this is where I talked about lots of images or lots of words on the slide, because I want you to have the information and know that these 8 domains are neurobiologically informed, and there's some citations here for further exploration if you're interested. So as individuals, we grow in these concentric rings of culture and social influence, global, national, ethnic, community, family, spiritual. Think Bronfenbrenner's cultural context, in the unique individual self. All those come together. And so you have a lot of research going on about social environmental effects on the brain, socioeconomic status effects on the brain, relational context for social neuroscience. And so when we talk about earlier stages of life, children and adolescents internalize these culture-based attitudes, and it becomes their reality, the lens through which they view the world, whether it's about substances or coping with stress through substances. And so that's the child and adolescent book that's coming out October, I believe. Very excited about that. So for me, this is the source, one of many sources for me, of compassion, empathy, and sympathy for the clients that we encounter, the loved ones we encounter, the person in the mirror that we encounter that has problematic behaviors, a troubled relationship with a substance or a behavior that has affected multiple parts of their lives, that we didn't choose the sociocultural milieu that we were born into. It kind of chose us. And it's part of dealing with the cards we're dealt with. And I have a whole little spiel on that I'll talk about a little bit in a moment. But Out of that flows beliefs about relationships. So we are defined by our relationships, and anyone who's ever encountered a person in active addiction or in recovery or in various stages in between, you see the vulnerabilities that they have related to relationships, whether they choose destructive relationships, partners, I'll change them, or they'll be okay, or they're a responsible user, it won't affect me, to how they grew up with relationships, whether they received the sort of the good enough parenting, I think I make a reference to that in one of these slides, or whether they were isolated, neglected, or abused. And so these attitudes are taught very early on about how the world works and how they relate to other individuals. I think if we do, and somebody posted a comment, I think I saw it blurb about relationship. I don't know how you do effective substance use treatment without a heavy emphasis on relationship skills, communication skills. More about that in a little bit. But also what we're learning from neurobiology, this is, oh, I have to tell you this because I can't not tell you. Some of these terms, embodied and psychophysiological approaches, physiological synchrony, interpersonal autonomic physiology, is the study of how humans interact with each other on an implicit level. So what that means for me, and if you ever, for those of you working in drug treatment, I have a theory that, of course I do, but it's been my experience that one of the main reasons a client will ask a provider if they're in recovery is not so much out of curiosity that that's there. Sometimes it's just to make conversation, but it's so that they don't feel alone and to gauge the threat of how much judgment they can expect from that person. Because if you haven't walked in addiction, it's really hard to understand the other person's experience. But the question is really about, do you have the capacity to hear my story without judging me? Because I can guarantee you that I'm judging me every time I tell my story. And so this interpersonal autonomic physiology, or this synchrony, is kind of the nervous system's ability to sense and perceive the authenticity of the other person. This is why I don't believe we can adequately fake empathy. And that if we objectify folks in addiction, folks in recovery, they know it, they sense it. These are some of the most intuitive, sensitive people that we'll ever meet, even when their behavior is contrary to that. And so the neuroscience is starting to really highlight how important it is for me as a provider to get my attitudes in check before I encounter the person sitting across from me or the person in the group, because their nervous system will know when I'm not genuine. And that, again, that calls for a greater level of integrity. You can't read an article or a book on how to do that. You have to look deep inside ourselves. Yeah, comment to neuroception, that connecting. It's better branding than some of these embodied and psychophysiological approaches. But yeah, polyvagal is another one of those theories that seeks to explain this. Early relationships set the stage for addiction, in addition to exacerbating addiction through relational exploitation. Most of the clients I've worked with over many, many years of substance use treatment or addiction treatment or substance misuse treatment, depending on their diagnosis and my agreement with their diagnosis, grew up in really relationally deprived environments. Now, sometimes that is about their perception more than the reality, which we know that that perception is tantamount to reality for individuals. We also know that healthy relationships early on inoculate the brain to stress, which serves as a protective factor. So early attachment is the process of the primary caregiver loaning their prefrontal cortex, their higher order processes and reasoning skills, to an infant or small child who doesn't have the same level of development, teaching them to pattern their development after this regulated other. So when my daughter is 3 years old and she's having a tantrum, and I get down on her level and I look at her with compassion, and I don't let her hit me or whatever the case may be. I'm not just a punching bag. Setting appropriate limits and connecting with her in a calm, rational way allows her to see and sense a new way of relating. And many of our folks that we work with have not had that experience. I didn't have that experience, and it's taken taken a long time to try to work through that. Yeah, I saw mirroring. Siegel talks about it as right mode to right mode right brain to right brain processing. Cozzolino calls it the social synapse, how we connect with one another. Okay, I've camped out there. I got excited. I told you, okay, I got to move on. Biology genetics. So a lot about epigenetics and how and experience dependent plasticity, which means there's 50% heritability in addiction, particularly in alcohol use disorders. But if you never open an alcoholic beverage and consume it, are you still an alcoholic, for example? Now, we could talk about dry drunks and the process of some of the same behavioral manifestations of that genetics. But what really happens is that our environment and our experiences switch on genetics. So that drive behavior. So this is passed down to us. So biological function includes sleep, diet, nutrition. Also, I think I mentioned this in an earlier slide, or I had it up there, is our body's ability, genetic pre-wiring, to metabolize substances that affects our propensity for developing an addiction. So epigenetics of heritability and traits, interaction of genetics and lifestyle, relationship between avoidance behavior and IBS in adolescence. So how our behavior in certain environments through certain experiences can activate genetic predispositions. And man, that really stinks, doesn't it? If you are genetically predisposed to something and your behavior, your environment, or your experience switches that on, and now you start to live a different life. Folks with type 2 diabetes might relate to this in that way. Okay. Environments, past and present. So this is part of that as well. Environments include previous and present. They shape all the development of humans, either facilitating or blocking growth in domains of human experience. And they usually include thinking, feeling, behaving, and relating. So low socioeconomic status, lack of social support systems, parental drug use, and poor quality of parenting, parental depression, sibling and peer influences, drug availability, school, neighborhood characteristics, advertising and media, and stress all kind of have these influence on subsequent behaviors and attitudes about behaviors. The role of modeling and mimicry in one's environment. This is basic modeling. Just learned that from Bandura and the Bobo doll experiments, and how environmental context influences neural development and subsequent behavior. Again, I'm not trying to go too deep with any of these, trying to lay the groundwork for how I understand addiction, neuroscience of addiction. Experiences exert influence on behavior and perception. I think this is huge, in part by activating a genetic coding that affects later functioning. So usually the way I describe this is if you line 10 people up and they experience, and they all witness the same traumatic event, only one or two of them may develop post-traumatic stress disorder. And that is about the way their brains process trauma. A lot has to do with their experiences and their biology. So what does that mean? to be blunt, it sucks for those people. The same with our stories of our folks who go to a bar with their friends. 5 of their friends walk away. The 6th has to be dragged out. It's just, it's a part of confronting the reality of what addiction is based on all these different factors and how we develop. And a lot of the things are choices that we never made. They were made for us, which I'll say more about in a little bit. Acute experiences on long-term memory. So I say trauma avoidance and modeling of behaviors are all key experiences that can influence the development of addiction, either through learning itself or through gene expression. So a lot of things that are outside of the control of the individual. This leads to behaviors. It's usually the target and the referent for counseling. So it's like a goal or the referral reason. Behavior itself is a response to a stimulus, and there's usually some sort of psychological phenomenon as a mediating variable, which affects other factors as we go through this. So really interesting Candle's work on a very simple sea slug called the aplasia, and really laid the foundation for the neurobiological basis of behavior. You have Hebb's rule, neurobiology of learning, and then Ledoux, the neurobiology of avoidance behaviors. Ledoux writes a lot about the neurobiology of anxiety. He has a book called Anxious, which is really good. It's not totally accessible because he's pretty bright, but it has a lot of really useful information for folks dealing with anxiety. Okay, feelings, affect, emotion, a specific or diffuse, future-oriented, subjective experience of fear and impending doom, antecedents of feelings. Antecedent feelings to addiction look like loss, grief, anxiety, depression, sadness, and the like. And then after use can include guilt, relief, fear, shame, and they really dominate. And a lot of the folks that we work with are dominated by our feelings. I do a lot of supervision in the community, and I consult on this almost daily, but definitely every week, that clients want to change the way they feel. And a very painful reality about changing feelings directly is the only way to do that is through a substance or a behavior of addiction or compulsion, or traumatic brain injury, which most people aren't on board for. The case of Phineas Gage, we had the pole run through his face and it changed his emotional responsiveness. We work with feelings, but feelings are subordinate to behavior. So those of us who feel more on the fully functioning side of the continuum, it depends on the day for me, subordinate our feelings to our behaviors. I don't feel like getting up and going to work today. I feel sad, I feel tired, but I do the things I need to do anyway. And for some of us, we're just lucky that we're wired that way. Some of us have had to really work to grow in that area, but the folks that we work with often are trapped in emotions as reality, emotions as drivers of behavior. And I think that is due in part to the neurobiology of addiction, how we process emotions. Emotions for some are all-consuming. They shape reality and they dictate behavior. For others, in certain areas of our lives, we're able to act in the ways we need to act, regardless of how we feel. So I have here some citations. It's really interesting. Panksepp, Jack Panksepp, just passed away recently. He's done a ton of work on the neurobiology of emotions, and he's identified 7 core emotions, and I have these here for you, the positive ones and the negative ones. And I think you can see that in addiction, both sides, the positive and the negative, are distorted. Okay. Okay, so I got through those. I might have skipped something. I just noticed the time. Let me just pause and regroup here for a second and see if there are any questions or comments that anybody has at this point that I need to attend to. is really an excuse to drink water.
At this point, it's mostly just comments. I think we can, just for time's sake, we can hold everything we can hold till the end.
Okay, great. Thanks for commenting. Thanks for having thoughts and feelings about this, whether you agree or disagree. Here is for later reference for you, locating addiction. Here's Volkow and Boyle. You'll see a lot of references to Koob and George Koob and Volkow, who've done a lot of work in the neurobiology of addictions. But this chart I want to show you is how I conceptualize addiction. So we've got the 8 areas, and each of these, I think that in terms of holistic care, we need to be able to attend to all of these. And that means problem definition, barriers to development, and then skills development in each of these areas. So again, I'll leave that up for a reference for you. Rather than reading all of these to you, I read some of the others to you, but so the outer ring is in this whatever teal color, green color that is, and the inner is also here. But all of these are identified in the literature as risk factors for developing addiction from early on. And so you see the things in the environment, you see the things in the individual's perception of reality, you see warning signs through thought life, feelings, behaviors, experiences, and biology. So one of the questions that I typically ask is, and this would be something you just think about, is where do you prefer to intervene with individuals? If you had to pick one of these 8 areas to start with, and how would you begin? So that's a question that I continue to wrestle with is, and I think it depends on the client, where we start. Because usually their presenting problem will be related to one of these domains and multiple of them. But a lot of times I want to know how has your sociocultural milieu informed your attitudes about drug use, about healthy relationships, about problem solving? So I think this gives us flexibility to enter where we think it's most appropriate, knowing that we're going to get to the same type of place. Okay, so here I've given you some citations regarding, we're still in the challenge of locating addiction. Where is it in the brain? You'll see this over and over again. The amygdala and its role in fear processing and threat detection, the hippocampus and how we understand memory. The nucleus accumbens is reward, so is the ventral tegmental area. These are both associated with the striatum, and I'm going to show you something that keeps blowing my mind, even though I talked about it for a long time. And then when we most often talk about reward, we're talking about the mesolimbocortical dopamine system. And so, but usually there's a bias toward a hedonic view of substance misuse, which is people do this because it feels good. But the neuroscience shows that that is only half of the story. I have a slide coming up to talk about that a little bit. How is it treated? There are lots of different ways, motivational and motivational enhancement therapies. Cognitive behavioral is often the one that's most studied because it's the most rigorously controlled, but it looks very different in the field than it does in a lab setting. Family-based, you know a lot of these. Oops, sorry about all the flipping. Conflict management, medication compliance. Oh, so the literature, at least from a neurobiological perspective, the experts in neurobiology of addiction treatment have indicated that for alcohol use disorders and opioid use disorders, naltrexone works, like the verdict is in, the Vivitrol shot, for example. But only 9% of substance abusers receive medical treatment. So now, I imagine a flurry of comments and questions about this and opinions about medically assisted treatment and recovery. That's not real recovery if you're on methadone or you're on Vivitrol, because you're still using a substance to stay away from substances. And others would say take a harm reduction approach and say, yes, but they're not destroying lives in the process of using this. A lot of clients will say, well, I'm not really using my willpower if I'm taking antabuse, for example. That's a, just a very simple thing. But I mean, if you're going to, my view is that if a client is strong enough to take antabuse, knowing that the reason you do it is so that it doesn't metabolize alcohol into sugar and you get really sick from it, that feels like a commitment, at least along the stages of change. Anyway, so that's a little soapbox. I'm not coming down on one area or the other, but I think that there's some research that could better inform what we're doing. Communication skills training, family-based work, the good enough parent idea. Do you know what I mean by the good enough parent? You can't tell me if you know, but the idea is that we don't have to be perfect parents. We just have to be available parents and to be able to respond. And a lot of the folks we work with have not had that minimal good enough parenting or responsiveness. Okay, here's another model that we don't have time to go into, but I really am interested in this. Remember, Coop says it's the reward deficit and stress surfeit disorder, but he's broken it into, and there's a lot of evidence now backing this up from some meta-analysis and lab studies that show it's best to maybe best to understand addiction as 3 processes, not one. It's not like addiction and we just got to treat addiction, but looking at the binge intoxication part of the cycle, the withdrawal and negative affect, and then preoccupation, anticipation. All 3, and you can see the corresponding regions of the brain. They're different circuits. Now, these circuits work together to create the gestalt that we call addiction. But what if we understood different treatment approaches based on the cycle, place in the cycle that an individual is? There's a lot to be said there. A lot for additional reading, giving you sort of the dates there and the names. It's pretty fascinating. Okay. I'm going to go through these next ones really quick because I want to show you just a few fun things as we go through. One of the things that we know about addiction is that it is not just about pleasure, it's about removing pain. And a lot of times that's the pain of not using. So what we realize is that this mesolimbocortical dopamine system, there are reward pathways, but the reward component is learning. And so what happens when I do this, I feel good, but it doesn't take many times to administer a substance of abuse for it to turn into, when this doesn't happen, I feel pain. And I think that's the problem with the hedonic view of substance use, is that I have not really met many people that wake up one day and say, I think that I will destroy everything and everyone that I love today because I have this thing in my life that feels good. I think it is the drink takes the man. That it is, and I think it's important for us to educate our communities that people aren't trapped in addiction because it feels good. They're trapped in addiction because it stops death for them, pain as death. And I think that that's borne out in the neurobiology of addiction. Okay, no time for soapboxes. So for me, early nurture builds self-regulatory capacity in the brain, which leads to a stress response that triggers the need for connection and the seeking of connection. But when you grow up in an environment that does not promote that, you seek something else. And then so the stress response triggers a need for something else, to connect to something inanimate rather than human. And I think it becomes substitutionary nurturance. And so I have that defined here. Substance often damage relationships so that even less relationship reward may be available to addicted individuals, driving them to drugs, which function as relational substitutes, further isolating them and giving them less practice in relating and relearning how to get rewards from relationships. Our folks have lost the capacity to find relationships rewarding. And this is because there are two morality systems in an individual with a substance use disorder. There is the morality system of the individual person, and there's the morality system of the addiction. So the things that the addiction says is okay to do, lie, cheat, steal, kill, destroy, is something that the individual, when they're sober, would never condone. And this is the paradox of treatment, is how does this person who has this belief system, this value system, cope with having done these things that are so in violation? It's because there's two different morality systems working at the same time, in my opinion. I'm going to skip over habits and goals. Oh, here's the thing. So in the striatum, we talked about that, the ventral tegmental area, the nucleus accumbens. You have the striatum, which has the dorsal medial and the dorsal lateral striatum. So the dorsomedial striatum is responsible for learning and memory, goal-directed behaviors. The dorsolateral is habitual learning and memory and compulsivity. An individual who doesn't know how to manage stress, who is in what we call a chronic variable stress, so the stress is repetitive, but it's unpredictable and it's uncontrollable, inescapable. When they live their lives like that, the dendrites, the part of a nerve that receives signals from axons, die in the dorsomedial striatum. So the capacity for goal-directed behavior is diminished. But guess what happens in the dorsolateral striatum that controls compulsive and habitual learning? Those dendrites proliferate. They grow when a person is exposed to chronic variable stress without the resources to manage it. What that means is that it's a type of brain damage where the individual loses the capacity to think in terms of goals, and instead can only follow patterns and habits from the past. I think that really opens the door for more compassion to what it means to treat an individual trapped in addiction. Their brains are trapped in addiction. It's not just their will. This is not about willpower. Again, if it was about will, people would not choose willingly to destroy those that they could or should hold most precious. Okay, now I'm just preachy and ranting, but let me. So the drink takes the man. This is goal-directed behavior in the dorsomedial striatum. The drink takes the drinks, which moves to habitual learning in the dorsolateral striatum. The drink takes the man becomes stress-induced dependence. It becomes this inability to process stress, to tolerate it. And so any stressor becomes a reason to use because stress is so intolerable. But it's not the colloquial stress that we talk about, I'm so stressed about work. It is stress that causes physical, psychic, and spiritual pain that people need to break from. Okay. So this is what I think a definition that I've been working from. Addiction is a relational disorder that manifests itself in disordered cognitions, behaviors, emotion processing, and social functioning and intimacy. Its origin can be traced to difficulties in receiving nurturance from primary caregivers, resulting in deficits in social and emotional regulation. These disordered brains, disordered in quotes, lead to compensatory behaviors that limit pain and outsource neuroregulation to substance behaviors, pathological relationships. I don't believe I have the capacity in myself to regulate, so I'm looking for something outside me to regulate. So in my opinion, treatment is a base where the individual with an addiction can relearn stress tolerance and emotional regulation, where they can be consciously and unconsciously experience how relationships can provide reward. So when Koob talks about addiction as a reward deficit, I think it's a relational reward deficit, because how do you replace a substance that never fails to deliver when the patterns of relationships that you've had have always been conditional? Your drug of choice is unconditional. It delivers. Now, I understand tolerance and dependence and that it doesn't deliver at the same levels. I think treatment can suggest that people turn to addiction when they feel overwhelmed by how imperfect, frustrating, boring, empty, and lonely life and human relationships can appear. It can also provide glimmers of reward that may help addicted individuals to tolerate these negative aspects. so that they're able to experience another equally authentic and real aspects of human life and human experiences, like laughter, understanding, compassion, and connection. And I just I'll wrap up on this note because I have a whole other presentation here, but I can't obviously do that. The concept of delayed discounting is that it refers to the decrease in value of a reward as a function of the delay to its receipt. It's a type of delayed gratification that says, if let's look at exercise. If I get up off the couch now, later on I'll feel better about myself. But it also feels really good to stay on the couch right now. So delayed discounting is me saying it won't feel that much better later than it does right now. So I'm going to stay here. So preferences between a sooner, smaller reward or a later, larger one reward. We've seen this in the marshmallow experiment redone, that there are other factors, not just willpower, that affect whether a kid eats the marshmallow now or waits for 2 later. But Bickle and colleagues found that memory training, basic memory training, reduced delay discounting among addicted individuals. So something as simple as training the brain's memory systems can help us reduce delay discounting, meaning essentially delay gratification. Stop minimizing the reward of a future behavior for what is immediate now. I think that's one of the most tangible applications of what neuroscience can do to inform how people change, strengthening the hippocampus and its memory systems that have been depleted through memory retraining, in order to help people remember that the payoff later is more worth it than the payoff right now. And this was shown in practice with folks in addiction. So, okay, so there's lots more. I don't know after all this ranting if I'll get invited back, but I'd like to be able to do that and do a part 2 if possible. So, but for right now, I'll end it there, and maybe we'll have time for some discussion or some chatting. Does that sound right, Martha?
Yes, and you will definitely be invited back. No, this is great. Okay, so questions. Can you explain what the valence system is? Maybe you might have already done that a little bit, but
okay, like from the research domain criteria?
Yeah, I think so.
Okay, so valence is just the magnitude of an emotional and cognitive experience. So negative valence systems are how we process things that we don't that are negative in our lives. And then positive valence systems are the opposite, so rewards. And you think about negative reinforcement versus positive reinforcement. Negative reinforcement is the removal of something negative, and positive is the adding of something that we like. So the negative valence system is really how we deal with the difficulties of life at a neurobiological level. So I mean, that's some words about that. I don't know if I'm really getting to the heart of that question, but I'm happy to try again if you give me a chance.
Then someone asked if you could describe unfinished cognitive development a little bit.
Unfinished cognitive development. Well, I'd like to know more about what they're thinking, because I have plenty of things I can prattle on about. Unfinished cognitive development. I'll tell you what I hear in the question and what I've experienced clinically. And this is the dilemma that we face, is we usually, sort of a rule of thumb is that the age of addiction, that when the substance misuse took over someone's life, or when a trauma occurred, is often, when it's unresolved, is often when development stops. So a lot of times what we see in treatment is grown adults acting like 3-year-olds. And that is not meant to be offensive toward those individuals, because we still have to treat them as adults, because chronologically that's where they are. But their ability to process information, to regulate their internal systems to communicate effectively and connect reasonably with other people's is so diminished that if you've seen a 3-year-old in distress, that's a lot of what we're managing in treatment. And that's, again, that's not meant to derogate any individual, but I think it does lead the way to candid conversations about how normal it is for them to do that and how much work needs to go back. So at 3 years old, according to Erickson, we're looking at autonomy versus shame and doubt. Can I see something rewarding in my environment and move toward it on my own and begin to meet that need for myself? This plays out with kids who say, I can do it myself, I don't need any help. And we want, as parents, to support them doing things that they are able to do developmentally. With the delay, so let me just stop there and see if we're getting close on that response, or if I.
Yeah, the person who asked it responded and said that was helpful. They just weren't sure how it was being used in the slide.
Oh, okay.
So.
Yeah, thank you for letting me clarify.
Then another question, do you have any videos or resources with this type of information that would be helpful for clients, family, and friends?
Oh, yeah. I I do. Do I remember them at this moment? I don't.
Well, it's something so we send out an email. We'll be sending out an email next week with the webinar recording.
Okay.
If you would want to put together maybe a sheet with any kinds of additional resources or anything like that, we could send that along as well.
Okay. Actually, oh yeah, on my cheat slides over here, I omitted 3 types of videos that I think are awesome for families. And so, yeah, I can just send those links to you and you can share those out. There's also a web channel, I think it's called Crash Course. They do a 2-minute neuroscience presentation, and they talk about various things. Even in that, they go a little bit deeper than I would hope. But I think there's some good stuff there. Oh, and let me tell you this one. Oh my gosh. So if you've not ever heard of Hi-Ho Kids, HIHO Kids, and maybe I can share that link too. They have this thing where they do kids meet. And so there's kids from like 4 years old to 12 or 13 years old. And then they meet all sorts of professionals and people in the world. And they're sort of led through an interview process, and they get to hear from a person their firsthand experience. And they have one where they meet a 16-year-old who is addicted to, I believe, he's used a lot, alcohol, weed, and heroin, I believe. And they ask him questions only little kids can ask, and he laughs and he responds. And so he's teaching them about his experience of addiction to little kids. And I think this is really appropriate for people of all ages. I show these types of videos in my class to demonstrate differences in culture. There are people who have experienced trauma, or like they're also cops and nurses and brain surgeons and people that they interview. I don't remember brain surgeon. That was just an example. But I highly recommend following their channel. They do a variety of different things, and it's a really good way to communicate with families about and clients about some of these issues.
All right, then another question we had come in was, which counseling intervention do you believe is the most effective used in counseling? I have used MI, CBT, REBT, and I started to try to use DBT too. Any interventions from those theories that you feel works best?
Yeah, well, as any good counselor educator, I always say it depends. It depends on what my client needs. I am more of an experiential practitioner, so don't tell me, show me. And so that's why I love group therapy so much, is somebody can be telling me their story, and I would rather them show me. So bring in some of the group members and let's talk it through. I think a core foundation to my practice is motivational interviewing because of its relationship to person-centered, Roger's work. And the core components of therapy, authenticity or genuineness or congruence, he calls it, empathy and unconditional positive regard. So, and so motivational interviewing grew out of that. And so I think that's my main base. And they're all the things that I mentioned are categorized under existential humanistic theories. So great question.
And then another one is, where is the top neuroscience-based addiction medicine treatment in the United States?
That feels like a pop quiz that I'm going to fail. If you find out, will you tell me? Because I don't know. My concern is that folks that say neuroscience are really just rebranding a medical model, which can be a mixed blessing. Oh man, I'll have to save that for the next time. Because
I guess, well, my question would be, which ones are there? Because I don't know, I personally don't know of any that are, you know, touting that they're neuroscience based. I guess if you had any.
No, I don't know of any off the top of my head. What I see mostly popping up are like, this is a terrible word, but kind of bougie. Again, if it works for people, that's great, but sort of high-end practices that are, gosh, I can only think in negative terms. I guess that really reveals what I think about it. They have very specific hooks to get people in, musically oriented if you're in Nashville, or farm oriented if you're in Kentucky maybe, and you know, equine therapy. So yeah, beware the newest trends is what I think.
Yeah, well, somebody did message while we're talking about that. They said the Meadows has great neuroscience treatment options.
Great.
So, and I think that's in Pennsylvania, I'm pretty sure.
Okay. That's something to look into. That's great. Thank you.
Then, so this is going back to something kind of specific I think you were talking about earlier in the presentation, but somebody asked, where is a good place to find out differences in metabolism? Often THIQ is discussed, but I am not sure if that is accurate.
Oh, so what's the first part of that question again?
They asked, where is a good place to find out differences in metabolism?
Wow, I think I don't know. Oh, okay. Well, the first thing that comes to mind is it's 23andMe getting your profile for weight loss, you know, finding out your genetic predisposition. And the reason I laugh is what I've heard is that the reports come back and say, well, based on your genetic profile, you probably should eat less carbs, you should probably exercise more and drink more water and get more sleep. And I feel like that could be true for anybody. So I think that it's a behavioral analysis that you can do on yourself. So a lot of times this is done through food charts or food journals. I see GARS test and a link there. Thank you, Crystal. A lot of times we don't track very well how we feel after certain foods or drinks or behaviors. And I think it's about becoming more mindful regarding how we feel, you know, within 15 minutes, within 2 hours, what's our energy level like? But as far as specific tests, I think the reference that was shared is probably a reliable way to do that.
Right. And then do you have time for one more question?
Sure.
This one might not be so quick, but I know we're at 1:30, so I just wanted to make sure you're okay with
Yeah, I'm good.
Is there a moment to expand on memory training, decreasing delay discounting, such as examples of tasks, tools, or methods to be used in memory training? And then in parentheses, they said, looking for methods to be utilized to teach clients. With stimulants being so prevalent right now and knowing memory training could assist with this.
Yeah, I think that's great. Well, I would encourage you to just do a Google Scholar search for Bickle and memory retraining, and they describe their methodology. But I think it's as basic as in treatment playing the game memory, forcing the mind to focus attention. Yeah, I see a reference to CBT. Also, DBT has a lot of these skill sets. Mindful practice. I'll tell you this. This isn't what you asked, and maybe because I don't have a good answer. But I will say there's an app called Insight Timer that it's free, and I mean you can pay a subscription. I did because I've been using it every day for a year, and I find it transformative. But about mindful practice, and you can use it just timer with background noise or not. You can do classes, but I think that we have to be able to help individuals direct their attention where they want it. So that is a good. I don't think so. I'm a full-time educator and supervisor now. I include it in my classes. I would not open a private practice again without that being a core part of the philosophy. Because memory in many cases is the ability to encode sensory experience. And we can't encode things in the same way if we cannot attend to them. And so how can we direct attention? So I think that's a vital part of our practice, is including those kinds of resources.
All right, Dr. Luke. Well, in addition to all the questions, there are plenty of positive comments coming in. People are saying they can't wait for your next webinar. Just saying that this was such a great presentation. They really liked a lot of the points that you made.
Cool.
But if you don't have anything else, then I would just like to remind everyone that a copy of Dr. Luke's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IREDA's website sometime next week. Once we have these resources posted, a link will be sent to all of today's webinar registrants. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation, and the second email will include step-by-step instructions on how to obtain your CEUs. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check your attendance records. We would like to specially request that you fill out our evaluation. It should take no longer than 2 minutes of your time. Again, we want to thank everyone for attending today's webinar. And if you have any questions, please email us. Our email address is info@ireda.org, and keep posted through our newsletters about upcoming webinars. And with that, I want to thank Dr. Chad Luke again for his great presentation today. And I want to thank everyone for attending. With that, I will conclude the webinar. Thank you so much and have a great afternoon. Goodbye, everyone.